Hello. Welcome to Family Medicine Grand Rounds. We'd like to thank the South Dakota Academy of Family Physicians, Avera Health, and Sanford Health for supporting Family Medicine Grand Rounds. We have Grand Rounds the first Thursday of September, December, March, and June at 12:15. So please come back or tune in if you are viewing this remotely. If you would like CME credit, there is a sign-up sheet outside of the room here. And then for those watching remotely, if you could email or fax your sign-in sheet, or if you're the only one there, just email us so we have record that you were in attendance. The next Family Medicine Grand Rounds will be December 5th at 12:15, and it will feature the peer residency program, including Drs. Huber, Serpin, and Campbell, and they will be presenting remotely from Peer. So that will be a first, and they just arrived in Peer this month, so we'll be anxious to hear what they have to present. So our speaker for today is Dr. Kelsey Hvidsten. She is a second-year resident at the Sioux Falls Family Medicine Residency Program, and she is a graduate of St. Olaf College, Northfield, Minnesota, with a degree in Spanish and Intercultural Medical Practice, and she's a graduate of Creighton University School of Medicine. She was part of a OBGYN residency for 3 years before coming to the Sioux Falls program. And she completed a research project with the Maricopa Integrated Health System in Phoenix, Arizona, enhancing culturally informed healthcare services for women affected by female genital cutting. The grant was funded by the Department of Health and Human Services and the Office of Women's Health. And we really appreciate her willingness to share this information with us. Let's welcome her.
Hi everyone. Like she said, I am a second year here at the Sioux Falls Family Medicine Residency. And today's presentation on female genital cutting is tailored more towards the primary care provider. So I'd like to start by saying I have nothing to disclose, no commercial relationship relative to this presentation. Currently, female genital cutting, which can, during this presentation, be used interchangeably with female genital circumcision or female genital mutilation, is a pretty hot topic. There is minimal prior research available, but given the grants that have been given to Phoenix and other various locations across the United States in the past 3 years, a lot of research is coming to conclusion, and we'll see a lot of publications coming in the next few years. So that's really exciting. My focus on research was in the deficits in medical provider training. I come from a family where my mom is a teacher, and so I have an interest in training medical providers. Maybe that's because I've always lived with a teacher. That picture there is a picture of me during this 8-hour provider training workshop that we did May 31st, 2018 in Phoenix, as well as June 1st, 2018 in Tucson, two of the first provider trainer workshops in the United States. That particular picture, I'm using a model to demonstrate how to perform the defibrillation process, which we will talk about later. The objectives, briefly, for this presentation include identifying the 4 different types of female genital cutting, describing common primary care concerns, understanding generally the defibrillation technique, as well as the implications female genital cutting has at the time of delivery, reviewing briefly legislation, and providing some provider resources. I would like to start this presentation with an exercise on perspective. I'm not sure how many in the audience have been in medical anthropology, but this is an excerpt of an article describing a culture well known to us that I would like everyone to think about which culture I may be describing. And then afterwards, I will explain why I use this. The daily body ritual performed by everyone includes a mouth rite. Despite the fact that these people are so punctilious about care of the mouth, this rite involves a practice which strikes the uninitiated stranger as revolting. It was reported to me that the ritual consists of inserting a small bundle of hog hairs into the mouth, along with certain magical powders, and then moving the bundle in a highly formalized series of gestures. And then I have an image that represents those hog hairs. Has anybody heard of the Nasarima article before? Yes. The image I have there is one of the first toothbrushes. Toothbrushes originated around the 1490s. I think the first one was seen in China. And this excerpt is actually describing a normal daily ritual, us brushing our teeth. And so I just want you to keep this perspective in mind of an outsider's description of a very normal daily practice as we move on to discussing a practice where we are the outsiders and where we don't understand the beliefs that are supporting the practice. And I'd also ask that everyone hold their questions until the end, as I'm sure there will be many. The World Health Organization describes female genital cutting as any procedure that involves partial or total removal of external female genitalia or other injury to the female genital organs, whether for cultural or non-therapeutic reasons. So to your leftmost is a depiction of normal female genitalia with pubic hair, and to your rightmost is a depiction of the most severe form of female genital cutting, type 3, also called infibulation. We will discuss all the types. After having performed this exercise on perspective, I wanted to emphasize the incorrect preconception that many have regarding female genital cutting. This is a practice that predates Abrahamic religions, which includes Judaism, Christianity, and Islam. And so that link to religion is mistaken. Justifications for female genital cutting. It is considered a rite of passage to womanhood. It can be considered part of family honor that the females in your family have this performed. It gives you a sense of belonging to a community, and if in particular you are a female in an arranged marriage who lives away from your prior family and lives with your husband's family, not only does it give you a sense of belonging, but it ensures that you will remain under their protection. And in certain cases, after delivery, they may request re-infibulation, so replacing the anatomy as it was prior to delivery, because they would not be accepted back into that family and support without that procedure. To women in populations where this is common, it can be seen as aesthetically pleasing because it is the norm. There are beliefs that you are not faithful in your marriage or may have had premarital intercourse if you've not had this performed as well. General information. The age at which it is performed is about age 5 to 8, but it can be performed from the age of infancy all the way up to the age of 18. Who performs it? Often it's women, so mothers, grandmothers, elders in the community who the child respects and loves. Because female genital cutting became illegal under federal law in 1996, there's a practice that developed called vacation cutting, where you take the child out of the United States to have female genital cutting performed whether that be in a country where it is medicalized, i.e. performed in clinics with medical supplies, or to a country where it is performed in rural areas by laypersons. If you examine a child that appears to have female genital cutting performed, it is your duty as a medical provider to report it as child abuse. So we are mandatory reporters. So where is female genital cutting performed in the world? There are 30 different African countries. Here on the map that you can find at the citation below from World Health Organization, it also illustrates where it's performed in Southeast Asia and the Middle East. I also placed this map specifically of Africa that shows you the countries in Africa where it is prevalent because of the populations of refugees we have in South Dakota. We have a fairly large population from Eritrea. We have refugees from Ethiopia, refugees from Sudan, refugees from Somalia. So when you are taking care of women who have immigrated from these countries, this is likely going to be a healthcare issue that you are going to encounter. And so I just wanted to highlight the importance of this issue in South Dakota. In 2016, a public health report with data from 2012 was published, and it stated that 513,000 women and girls are at risk or are already affected by female genital cutting. This obviously was a very difficult number to calculate, difficult data to collect, and when they state affected by or at risk, it means the woman has already had it performed, or it is a girl who is at risk of having it performed in the future. So it's a very rough estimate, but it does give us a concrete number to show that this is an important healthcare issue in the United States. And then I also included from this public health report an image of the United States with the darker states having higher prevalence of women who have had female genital cutting performed or at girls who are at risk of having it performed. The citation below is where you can access this information. Okay, so we've talked about the definition by the World Health Organization, and now we're going to talk about the 4 different major types. The first type you can think of as clitoridectomy. It includes any procedure that removes the clitoris or the prepuce. The prepuce is the covering of the clitoris, just like with male circumcision, you're removing the foreskin. With clitoridectomy, you may be removing, quote unquote, the foreskin of the clitoris or the clitoral gland itself. In type 2, generally called excision, you're going to be removing all or part of the labia minora, and this does not include what type of removal or surgical adjustment of the labia majora has been performed, nor does it include whether or not the clitoris or the clitoral covering has been removed. In type 3, the most severe form of female genital cutting, called infibulation, which is a term you're going to hear throughout this, it's specifically narrowing of the vaginal orifice with sealing of the perineum by cutting and repositioning the labia minora and or labia majora with or without excision of the clitoris. So basically, whether or not you're using the labia minora and the labia majora, just the labia majora, and whether or not you have surgically excised the clitoris or not, you're going to be narrowing that vaginal orifice and sealing it to the perineum to make a very small neo-introitus. And we're going to go over all those types. The 4th type is kind of a catch-all. Any harmful procedures to female genitalia for non-medical purposes. And we won't go into detail regarding this, but know that there is a process of genital pricking, which is a way that the American Society of Pediatrics did initially try to adjust for this ritual by just pricking the clitoris, getting a prick of blood. That's not supported by them, but it was a thought previously, or piercing. So I'm not going to go into detail, but it's kind of a catch-all category. Just a quick anatomy review. So to understand these types, you need to know anatomy. I'll use the mouse here. So the prepuce here, you can think of as the foreskin of the penis. The clitoris here is the clitoral gland that is covered by the prepuce. You're going to have the urethra, more inferior, and more inferior to that, you have the vaginal introitus. Laterally to all these structures, you're going to have the labia minora, and more lateral, you'll have the labia majora. Those are the structures that we're going to be focusing on with these different types. And of the three major types, there are subtypes as well, which I will touch on briefly, but aren't as important to us as primary care providers as it may be to a surgical provider. Okay, this is drawn directly from this article on female genital mutilation, which also provides instructions on defibrillation. I'll have it listed at the end for provider resources. First, I'm going to talk about this type 1 clitoraldectomy and the two subtypes. Okay, here you see with type 1A, they're removing the covering of the clitoris, and type 1B is removing the covering and the clitoris itself. A lot of times on exam, you won't even notice this because female genitalia do differ from female to female, and this is not something that you may always notice on a brief exam. Type 2, which is generalized to excision, has 3 subtypes. In this first subtype here, you have removal of the labia minora. When you're thinking of subtype 3 or type 3 later, the labia minora may be removed, but the main difference is that you're not going to be closing that vaginal orifice and making that neo-introitus. You're only removing the labia minora, which still allows for that same size vaginal introitus. Type 2B is going to be the labia minora, as well as partial or complete removal of the clitoris. And then type 2C is going to be removal of the clitoris, labia minora, and labia majora. But the difference, as this is climbing to type 3, is that you're not closing that orifice, whatever tissue remains, to make the neo-introitus. Now we move to type 3, infibulation, the most severe type, which has 2 subtypes. And in these images here, they actually show you where the suture, or if done in a rural area, thorns are used to close this tissue at position, the remaining tissue together to make that new neo-introitus. This is where the incision or the sutures would be made to close that tissue. Type 3 is showing that you're removing the labia minora, possibly the clitoral covering and the clitoris, and then you're appositioning the labia majora with this suture, as such, or with thorns, which is generally used when they don't have medical supplies. And then type 3B is going to include removal of the labia majora as well. And sometimes you'll find that the labia minora have been removed, and sometimes on defibrillation or the procedure to undo infibulation, the type 3 female genital cutting will show that the labia minora are still there and may show that an entire intact clitoris is there as well. This here is a picture of type 3 female genital cutting, which is called infibulation. You see that the remaining tissue here is appositioned. There's no evidence of a clitoris or clitoral covering, although when you perform defibrillation, you may find an intact clitoris or remnants of the clitoris. Here you cannot tell if there's removal of the labia minora or not. This here is the very small neointroitus, where from a woman urinates, her menstrual blood will be evacuated slowly, and any physiologic discharge as well will be exiting this very small introitus, neointroitus, which appears to be smaller than the anus in this picture. Okay. I know because we're family care providers, many of us do deliveries. And so implications for female genital cutting at the time of delivery. With type 1 to 2, you may or may not notice this difference in anatomy, and it's likely not going to affect your care. With type 3, that's when you're going to be thinking about performing a defibrillation, which is also just seen as an anterior episiotomy. This can be performed prior to induction, so you can have someone scheduled, get them an epidural, perform the defibrillation, and then start the induction to follow. Or it can be performed at the time of somebody presenting in active labor, just prior to delivery of the head. And we'll talk about the procedure of defibrillation to follow. Type 3 female genital cutting or infibulation is not an indication for cesarean delivery. There's an article that all OBGYN residents have to read called Preventing the Primary Cesarean, and that'll highlight the maternal reasons, the fetal reasons, and the labor dystocia reasons for a C-section. And nowhere in there is female genital cutting, because female genital cutting is a tissue dystocia, which can be alleviated by natural laceration as the infant is born, or defibrillation can be performed. This is a fear of a lot of women in cultures affected by female genital cutting, that they're going to be forced to have C-sections. And that's why I really highlight that in this talk. The process of re-infibulation on an adult female is not considered illegal. So if a woman has defibrillation, delivers, and then requests re-infibulation, it is your role as a provider to educate her on the morbidities of female genital cutting, which we'll be talking about later, as well as offering her treatment options. I like to reconstruct the anatomy partially superiorly while leaving the urethral meatus and vaginal orifice uncovered, which will help with a lot of the medical comorbidities such as urinary tract infections, pelvic pain from dyspareunia, or from menstrual difficulties. But I wanted to emphasize that if a woman is in a situation where she does not have complete re-infibulation, she will be kicked out of her family and not have any support in the country. And if she understands the medical comorbidities that come along with female genital cutting, it is her right to make a medically informed decision regarding that care, and that would be us respecting her autonomy. If the female is a minor, she cannot consent to that procedure, and it is illegal. So I'd like to just highlight that distinction. So, to clarify some of the importance of our role as primary care providers, like always, it's very important that we counsel patients and that we provide education. Specifically for women affected by female genital cutting, we need to counsel them and educate them on the health risks of female genital cutting. We also need to counsel them on screening in general, and what you would think about with a woman with female genital cutting is if they have type 3 female genital cutting infibulation, you cannot perform a pap smear unless they are defibrillated. And so you have to counsel them on the risks of not having the screening performed and the treatment option of having defibrillation performed, at which time you would be referring them to likely a gynecologist who can perform the surgical procedure. And otherwise, we're going to talk about the morbidities related to primary care I'm not focusing on the immediate acute morbidities of the procedure. I'm focusing more on long-term morbidities, which include urinary tract infections. If you have type 3 female genital cutting, you are urinating by letting the urine dribble out of that small neointroitus, which will lead to urinary tract infections. That is something that we can treat. They may have pelvic pain. This can be related to dyspareunia. It can be related to complications of healing, maybe a chronic complication like an epidermal inclusion cyst, scarring, keloid formation, recurrent vaginitis, given your physiologic vaginal discharge is going to be exiting through that small introitus as well, and menstruation difficulties, which generally is pain. All of these issues you have to recognize, and during your history, ask them if they are having any difficulties so that you can catch these problems and treat them, and also keep them well informed of their treatment options. Some of the research that my colleagues did in Phoenix included these forums with females from the community only, as well as with males from the community only. The forum that they did with males included a survey, qualitative, that 80 men answered, and 90% of men in this community, specifically in Phoenix, said that they were opposed to female genital cutting. They said that, one, if there are so many health risks, we don't need to perform it. Two, it is a practice that has been performed by women and we don't have any role in the decision. And three, in some countries that they lived before, it was legal to perform female genital cutting. And as they live in another country now, they feel that they should follow the laws of the country they live in. This goes against some of the beliefs regarding the practice that it was man's role to decide to infibulate and remove clitoral tissue to not only ensure premarital virginity and faithfulness within the marriage, but to remove pleasure from intercourse to also deter infidelity. But that survey suggests that it's a practice that women performed because they thought men wanted it, but that was not confirmed with that survey. Of course, the number in that study was small at 80, but it's pretty groundbreaking research. Dr. Adrian Garza was the resident. He graduated last year, and so I believe a lot of that research is going to be published soon. So I'm excited for a lot of the research that we will have soon. I just kind of included this as a question that may be asked. If a girl is having female genital cutting performed, more likely she is going to have it performed in a rural area and she does not receive anesthesia. Another question that the audience may have is, if you have type 3 female genital cutting, how are you becoming pregnant? You can have the male ejaculate onto the external genitalia, and sometimes following marriage, you can have serial dilation with more progressively penetrative intercourse. Now here I'm going to briefly describe the process of defibrillation. So undoing the type 3 female genital cutting also can be thought of as an anterior episiotomy if you're thinking about posterior episiotomies at the time of delivery. Okay. Here is the area highlighted that they remove at the time of infibulation. You can tell that this woman likely had closure with thorns, as there's that lacy appearance of the tissue. There's no evidence of any clitoral remains, and they use a cotton swab here to emphasize how small that neointroitus is. This next picture, they first are going to mark the incision, because as you give local anesthesia, it's going to distort the original anatomy. And then they're going to use a Kelly clamps to elevate that overlying tissue and to also protect the underlying tissue. This makes the procedure look very simple, but you can encounter adhesions that you have to carefully excise, given limited visualization as well as the underlying anatomy that you're trying to protect. Okay, so after you've elevated the tissue with the Kelly clamps, you incise along that tissue. Sometimes you're going to have the open skin just along laterally. Sometimes it will come to form a V. A lot of times when it comes to form a V, that's when I will close a little bit superiorly and then separate and close with a running suture laterally. This is just demonstrating that in this picture here and this picture above here, you have remaining clitoris, you have the remaining urethral meatus, you have the vaginal orifice, and then the tissue laterally many times does not bleed much because of the scarring. Okay. The next step after excising along the midline is to use a single suture, and you can just close in running fashion. Generally, you'll use the same suture that you'll use for perineal laceration, and you allow it to dissolve. Intercourse is not recommended for a minimum of 6 weeks so that this tissue is not reopened. Okay, I'm not going to talk in depth about this. Much of this is something that you can look up on the internet. Specifically, the state law that South Dakota has, you can just Google female genital cutting to a minor is illegal, as well as vacation cutting. And that's just something that you can just look up South Dakota law versus female genital cutting in South Dakota. So female genital cutting is a form of child abuse. The issue with the practice is consent. It is considered a form of plastic surgery with the adult, and an adult can legally have infibulation performed, just like an adult can have a vaginoplasty and have the size of their labia minora decreased if desired, which is a procedure that is performed. As we all know, child abuse is punishable in every state. There are only 26 states that specifically criminalize female genital cutting, and we are one of that states. So South Dakota does criminalize female genital cutting. The first federal statute against female genital cutting was passed in 1996, so actually fairly recent, and it was not amended to include vacation cutting or transport out of the country until 2013. So that's a pretty big gap. Just food for thought. There's also the statute here where U.S. immigration officials are providing immigrants with information about the physical and mental harm caused by female genital cutting, as well as legal consequences in the United States. So when they immigrate, they understand that this is a process or procedure that is illegal here. And they're getting at least the initial counseling on the physical harm. But as you can imagine, this is probably a poor analogy, but with anyone who's getting a diagnosis of cancer, they may not remember a lot of information regarding that diagnosis. And so it is still our role as a primary care provider to counsel regarding the morbidities with female genital cutting. This is a map of the United States showing which states have laws against female genital mutilation. All of the states in gray, including South Dakota here, have laws against female genital mutilation, in addition to the federal laws that banned female genital mutilation as a felony, child abuse, and vacation cut as a felony as well. They also list the metropolitan areas with the greatest population. So New York, Washington, and then just 4 hours away from here, Minneapolis. Briefly, to go over the timeline of legislation, the Federal Prohibition of Female Genital Mutilation Act, making performing a female genital cutting or infibulation procedure illegal, was passed in 1996. The United Nations started to work against female genital mutilation as a human rights violation in 2012. In 2013, vacation cutting was added to the Federal Prohibition of Female Genital Mutilation Act. 2015, House of Representatives starts to get involved, and most recently in 2017, Stopping Abusive Female Exploitation Act of 2017 was passed in the United States House of Representatives, and that's increasing the federal penalty to 15 years and is starting to urge states to employ mandatory reporting policies. And yes, it is mandatory to report female genital cutting as a form of child abuse. Provider resources. The WHO has a great extensive packet on management of health complications from female genital mutilation. And so I included that on this slide here. The next dot there, Dr. Abdul Qadir is a worldwide specialist who runs a clinic in Geneva for female genital cutting. And this is a visual reference and learning tool in regards to how to perform defibrillation. So that is an article that is useful that you can look up, and it has a lot of the images that I use in today's presentation. Because the Department of Health has been involved in a lot of the recent research, they have developed a national provider list of female genital cutting experts. The moderator of this Excel list is Dr. Ranit Misori, who works at Georgetown. If you email her, she is able to give you the Excel sheet that's most updated as they continue to add specialists available. Unfortunately, they don't have any specialists currently on that list from Minnesota or North Dakota, South Dakota, Iowa, nowhere close to us, which I find very odd because there are a lot of providers who are very comfortable with female genital cutting in Minneapolis, but for some reason, nationwide, there seems to be a disconnect with the providers in Minneapolis and the providers with this national movement. Not that they're not doing research, but a lot of the research is not in conjunction with the other providers. I also can provide you with contact information for Dr. Krister Johnson-Agbahu. She was the primary investigator for this 3-year, $2 million grant that just completed this past year in Phoenix. She is one of 2 nationally renowned specialists on female genital cutting. The other nationally renowned specialists being Noel, which was her mentor, who works at Brigham. And I can connect you with a more local specialist, Dr. Fatima Sharif Mohammed. She practices in St. Cloud. She is Somalian, does speak Somalian, and does practice defibrillations, as well as works more with sexual identification in women who have had female genital cutting performed. I've spoken with Avera OBGYN as well as Sanford OBGYN, and they are both available for referrals if you have patients that want defibrillations performed. And the AAFP actually has a pretty good article on female genital cutting too. Okay, kind of to tie this presentation into my beginning, which may have seemed a little bit odd, I wanted to end with the beginning in mind. Please remember the Nasarama toothbrush. Your patients affected by female genital cutting depend on your counseling regarding healthcare screening, treatment options, and morbidities from female genital cutting. to make informed decisions regarding their own health care. Please respect their autonomy, even if you don't understand the underlying beliefs that are guiding their decisions. This is a picture from after completion of our second 8-hour provider training workshop. In red highlighted here is the primary investigator, Dr. Krista Johnson-Agbaku, who is nationally renowned. And I put another highlight here just to emphasize how important our cultural navigators were in this process of gathering the opinions from women and men in this community that did not trust health care. Questions? Yes. They did not have it performed in the United States or did not travel outside of the United States to have it performed and returned. We are not mandatory reporters. I think it would be best to report, but then also include in your report that they had just arrived to the country and let them decide. Because this is not, it's definitely very gray area. Dr. Hogue? I am implying that when I first changed to family medicine, my understanding that any type of reinfibulation was illegal. And I had a talk with Dr. Krista Johnson over the past few months as I've been preparing this talk. I had multiple talks with her. And she emphasized that it is in fact not illegal because it is considered plastic surgery. And the illegal portion is that a minor cannot consent. So when I first moved here, I also had the incorrect belief that it was illegal. So I don't think tides are changing. I think my understanding is changing. Yes. Yes. Five to 8, but it can be formed anywhere from infancy to the age of like 16 to 18. And I didn't really touch on current topics because I was a little worried about opening a can of worms. But there has been a history of women exercising their rights by performing infibulation on themselves at the age of college within dorm rooms. I can't tell you where that was, and I can't tell you when, but I'm letting you know that it can be performed much later. Yeah. I'm sure there is, but I would have to look for it. I think because you perform procedures on women all the time for plastic surgery that can have comorbidities, and because you counsel them on the risks of the procedure, that if you're an adult, you can make your own decision regarding whether or not the risks of that procedure is okay in your lifestyle. Because specifically with some women, how can you justify not re-infibulating that woman if she will now have no support from the only family she knows in the area, and now be disconnected from the rest of her family. If she feels that the risk is less than the harm of being separated from her family, her support, her children, how can you make that decision for her? I still don't want to do it, but I would have to have that discussion with the patient. How about in the front here? I've been seeing lots of facial expressions. I feel like you have questions. Nope? Okay. Anybody else? I am honestly not sure how the legal process works, especially with that physician that performed it in Detroit. So I would have to look more into that. I don't understand that aspect. Yeah. Thank you, everybody.